So first we're going to start, I'm going to just go over briefly like with cardiac output, because of course cardiac output is a big factor in our complications, not only complications heart-wise, but if we don't have good cardiac output, it affects every organ. Our heart needs to perfuse our whole body. So if we have decreased cardiac output, we're going to have decreased organ perfusion in general. It's not going to just result in heart failure, but it's going to affect a lot of other things. A cardiac output is the amount of blood pumped by each ventricle during a given period. It's usually between 4 to 8 liters, which 5 liters is about our average cardiac output. Our cardiac output, simply put, is our heart rate times our stroke volume. Our stroke volume then is affected by these 3 things, but our stroke volume is the amount ejected per heartbeat, and it's controlled by preload, afterload, and contractility. So our EF is calculated by our stroke volume. It's a calculation with our stroke volume and how much blood the ventricles hold during diastole. So our stroke volume plays a big part with determining what our ejection fraction is. But preload, when you think of preload, afterload, and contractility, think of a balloon. Think of your heart kind of like a balloon. Your preload is the stretch of the blood coming in to the heart. So before, so preload, things coming before into the heart. So it's affected by fluid volume, blood volume, those type of things. So your preload is like your balloon being filled with air. So the air that you're putting into the balloon is your preload. And then your afterload is the neck of the balloon. It's the resistance. It's what the heart has to pump up against in order to get it to the rest of the body. So your afterload is like the neck of your balloon. So the tighter you hold that balloon, the harder it's going to be for that balloon to push the air out. And then if you let go, the balloon will go flying around the room. So it's easier then. It decreases that afterload, decreases that resistance that the heart needs to pump up against. And then contractility is just as the name sounds, it's the heart contracting. It's the force that the heart has to pump up against to get through the afterload. So if you think of it kind of like a balloon, and of course pre, again, meaning before, after meaning after. So pre is what's filling, and after is what it's pushing up against. So factors that affect our preload. Our preload is going to be affected by volume. So the reduction in blood volume is returning to the heart will decrease our preload. So things like diuretics, diuresis, dilating agents, excessive blood loss, and loss of body fluids as well. So dehydration, all those things will decrease our preload. And then to increase our preload, we do the opposite. We increase the circulating volume, whether it be blood or fluids. That's how we need to increase our preload, is by basically, simply put, administering blood or IV fluids. And then your afterload is things that can affect your afterload, anything that's going to affect that resistance. So the less resistance, the more vasodilated, it's going to decrease that afterload. So things like our nitrates as well, calcium channel blockers, so hydralazine, minoxidil, are also meds that can decrease our afterload. Increasing our afterload then is things that are going to cause vasoconstriction, things like Lvad, our norepinephrine. I was trying to think of the generic name of Lvad. Neosynephrine, another one. So again, anything that's going to decrease the resistance, so open things up, vasodilate, that's going to decrease our afterload, and things that are going to increase our afterload are going to cause more constriction. So if we want to increase our afterload for like hypotension or something like that, we're going to cause vasoconstriction to increase that afterload. So all those things can affect our cardiac output. Decreased cardiac output eventually can lead to heart failure. I'm going to discuss heart failure just a little bit. I'm not going to go into super depth with it because it's more of a review. But when we're talking about, for this exam, don't concentrate so much on heart failure specifically, but now we're going kind of more into the big picture of things that are affected by heart failure. So So, you know, our cardiomyopathy and stuff often leads to heart failure. So we're going to talk more about cardiomyopathy. So just things that are decreasing our cardiac output and stuff, but we still need to be familiar with heart failure and the medications that we use to increase or decrease or preload and afterload that we're going to talk about. So heart failure, by definition, it's just a general term for the inability of the heart to pump sufficient blood to meet the needs of the tissues for oxygen and nutrients. Very, very basically, it's pump failure, either right or left-sided, but it is a pump failure of some sort. It used to be called congestive heart failure. I mean, we still call it congestive heart failure, but congestive heart failure is not really all-inclusive of the different types of heart failure that we can have. So here is a video. It's like 10 minutes or so. I'd encourage you to watch it on your own. I'm not going to put it up today since I don't have, because of time constraints, but it's there. It's a really neat way of thinking about how compensation occurs with heart failure. The heart, basically put, the heart is going to continually do what it needs to do to compensate for the decreased cardiac output or decreased preload or afterload, whatever the problem is. The heart's going to continually try and compensate until it can't compensate any longer, and it just results in flat out failure. So it's just a really good analogy, and it kind of puts it into simple terms of how to think about your heart when you're thinking about those compensatory mechanisms in heart failure. So I definitely encourage you guys to watch that video. So we have our different types of heart failure, left and right. So our left-sided is our left ventricular failure, and our right-sided is right ventricular failure. So with left-sided, we do have two different types. We have systolic and diastolic. So systolic is when the left ventricle is unable to contract forcefully enough, but diastolic, you know, rest, is when the left ventricle is unable to relax and fill enough. So when we have left failure, it can't pump to the body the way that it should be. So things start to back up into the lungs. And then when we have right failure, it can't pump to the lungs, so things start to back up in the body. So that's why with right-sided heart failure, we have more edema and JVD and stuff like that, whereas with left-sided, we have more pulmonary congestion. So with this, then we have our different signs and symptoms that I already mentioned. If you click on that, it just makes it sound like that crackles. It's just a couple different links to what those crackles sound like if you haven't heard them before or if it's been a while. So since our left-sided failure is our left ventricle, you're going to have decreased cardiac output. You're going to have a lot of those signs. It can be more life-threatening because it can severely impair the rest of our organs, you know, cause organ hypoperfusion. So, and then also with the pulmonary congestion, it can result in pulmonary edema, which can happen rapidly. There's what's called flash pulmonary edema, where it just occurs suddenly, and they fill up with fluid, and it's essentially like they're drowning from the inside out, and it can become very life-threatening. Right-sided, then you have more the edema, JVD, often occurs a little bit more gradually, but oftentimes patients might have both. Once one side of your heart starts failing, it does often result in, you know, full heart failure. So it's not uncommon, as we know, to see patients with both symptoms of left and right-sided failure. So with our diagnostic testing, we know that with any fluid imbalance, whether hyper or hypovolemia, we have electrolyte disturbances. So monitoring lab values, and then also if they're on any type of diuretics, we know that it's important to monitor our potassium levels. Our BUN, creatinine clearance, so monitoring our kidney function, because again, if the heart is not pumping well, the kidneys are not being perfused, that can start decrease our urine output and cause our BUN and creatinine to rise. H&H, again, you know, we could see some anemia as a result. But so our biggest diagnostic testing when it comes to CHF is our BNP, our B-natriuretic peptide. So that is specifically like a hormone that's excreted in the heart, and it will be it'll be very high. It'll be, I think it's over 100 when it starts to show signs of heart failure. So our BNP and our chest x-ray are going to be our big diagnostic tools when we're looking at like pulmonary edema and stuff. Our chest x-ray is going to show that fluid volume. It's going to show, that there's fluid in the lungs, but our BNP is going to be able to differentiate between whether it's cardiac related or pulmonary related. If it's cardiac related and that chest x-ray is showing that fluid, that BNP is going to be elevated. If it's not related to heart failure, then that BNP will not be elevated. So that's our biggest diagnostic tool, and able to differentiate between the two. And then of course we have EKG, our echoes. Echo is going to be able to tell us what our ejection fraction is, tell us kind of how well our heart is pumping. Because later, in the later stages of heart failure, it will really start to decline. A normal EF is right around 60%. So, nobody has 100% EF. So 60% is right around normal, but those that are starting to get into severe decompensated heart failure can go all the way down to around 10%. So that's when they start really looking at different treatment options to better prolong their quality of life. And then we have our thallium imaging and our mucus scans as well. But our biggest ones are going to be our BNP, our x-rays, and echocardiograms. So then we have different medical management, non-surgical, to help with, cardiac output as best we can to help improve that heart failure. We've got meds to reduce afterload, interventions to reduce preload, drugs that enhance contractility, and other non-surgical options as well. So first we have our meds to reduce afterload. Our ACE inhibitors are our most common kind of go-to drugs first, which are ACEs, are the ones that end in pril. They suppress the renin-angiotensin system and prevent that conversion of angiotensin 1 to angiotensin 2, which is a potent vasoconstrictor. So it helps increase our stroke volume, blocks aldosterone, which then prevents sodium and water retention, which will help decrease that fluid overload. So with our ACE inhibitors, again, they're usually the first drug of choice, but some patients don't tolerate ACEs. It can cause their potassium to rise. So if they have a more elevated potassium, then they have also, some patients have like this just dry, consistent nagging cough that comes with a side effect of your ACEs. So if for whatever reason they're not able to tolerate those ACE inhibitors, they'll switch them to an ARB. It has similar effects, but does not have some of those other side effects. So they're a little bit more expensive too, so that's why patients usually start out with ACEs. But if they can't tolerate it, or if it's contraindicated, if they have like renal failure or something like that, they're going to switch them to an ARB, which are ARBs are the ones that end in artin usually. So like losartan would be an example of an ARB. And then we have our BNP, our human B-type natriuretic peptides. So this helps treat acute heart failure. And with this is generally used in acute cases. It's IV, and it helps, endogenous BNP is released in response to that decreased cardiac output and causes natriuresis. So what these medications do is help cause like a diuretic effect without it being a true diuretic. So oftentimes it'll help improve cardiac output. Improving the cardiac output will help improve urine output, because if the kidneys are getting perfused better, then hopefully then they'll be able to start releasing some of that fluid as well. But usually, like I said, Nesteride is a common drug that we use for this, but it's going to be more in acute cases, and it's going to be given as an IV form. So then we have interventions to reduce our preload. This would be like your diet therapy. We know that anyone with heart failure or heart conditions or volume overload problems should be on a low sodium diet. That's a big thing. So making sure that they're understanding and compliant with that low sodium diet to help reduce that water retention. So generally 1 tablespoon of salt is equal to 2 grams. So if they are someone that adds a lot of salt to their diet, whether in cooking or just adding it, to their meals, just something that you should really educate them on eliminating, because that adds up quick to that 2 grams. So just eliminating that. It is possible, using salt substitutes, but salt substitutes, the problem with those is that they contain potassium chloride. If they're on a potassium sparing diuretic, or they have potassium retention problems already, then they should not be using those salt substitutes either. So it's, they just need to be very careful with their sodium and their salt substitutes, and know what type of medications they're on that are potassium, as far as diuretics, whether they're potassium sparing or potassium wasting, because we know that's really important. Other products that are high in sodium, then milk products are actually pretty high in sodium. So we know that cheeses and stuff like that have a lot of sodium, but milk in general, which cheeses are a byproduct of milk, so they do have a lot of sodium in them as well. Diuretics help enhance our renal secretion of sodium and help reduce the circulating blood volume, which helps decrease our preload and reduce pulmonary and systemic congestion. So we know, again, knowing the difference between our loop diuretics, our potassium wasting, and our potassium sparing diuretics, so like spironolactone is our potassium sparing. So just educating the patients on that with their diet therapy, as far as what type of diuretics they're on as well. And then we have our nitrates, our venous vasodilators, also helps, again, with that pulmonary congestion and dyspnea, because it helps decrease our preload. Then we have drugs that enhance our contractility. So most commonly we use our inotropic drugs. Our inotropic drugs are really going to improve contractility, strengthen the force, but vasodilators and beta adrenergic blockers can be used as well. We know DIG is a common drug as well that sometimes heart failure patients are on. We need refresh yourself on the DIG toxicity and those type of things. What's one of our signs of DIG toxicity?
Visual disturbances.
Yeah, visual disturbances. I heard something else. Somebody say something else.
Tinnitus.
Tinnitus. Is that one? I can't remember. I was thinking of the visual and like GI disturbances as being the main ones. And then with any of the medications or beta blockers or DIG, anything like that, or even our diuretics, they need to know how to check their heart rate and their blood pressure. Diuretics more so with their blood pressure, because we know if we remove fluid, that can cause blood pressure to lower. And then of course, if they're on any of these medications that can lower their heart rate and their blood pressure as well, you need to be doing education as that, making sure they know how to do that when they go home. An example, so our beta blockers, we know our beta blockers end in our LOL, but there's a difference between cardiospecific and cardiac non-selective. So metoprolol, atenolol, those are our cardiac selective beta blockers, whereas like propranolol is not. So it can actually cause, those non-cardiac specific beta blockers can actually cause bronchospasms. So if it's a patient that has any type of pulmonary problems, then you need to be aware of that and make sure, that those patients that's in their history, whether or not they have those lung problems, because they should not be put on those non-cardiac specific beta blockers. And then I've already mentioned this, not only do diuretics help improve urine output and remove fluid, but just any medications that are going to improve contractility or improve cardiac output will help remove fluid just by perfusing the kidneys better and getting them to work better. Other non-surgical options, CPAP helps reduce preload and afterload. Again, just decreasing that pulmonary congestion and stuff. Cardiac resynchronization therapy, we'll talk about that when we talk about the pacemakers. Essentially gets the ventricles to beat together, so that way it improves cardiac output. So with heart failure, your left and right ventricle usually are not synchronous. They're just because, if it's a result of the left ventricle being more hypertrophic, that doesn't sound right, but more hypertrophied, So, you know, it's not going to beat together with the ventricle. So just by having that desynchronization decreases cardiac output, decreases ejection fraction. They should be together simultaneously. So that's what your biventricular pacemaker does. It helps get those two ventricles to beat together at the same time by stimulating them to contract. And then that in turn helps improve cardiac output and improves their ejection fraction. And then you have gene therapy, which replaces the damaged genes with modified ones that goes directly into the left ventricle. I've never really heard of that done. That I know of, have had a patient like that, but it sounds fascinating. So then we have our surgical management. So our heart transplant, if heart failure gets worse enough and there's just no reversing it, no improving the ejection fraction or improving their quality of life, then heart transplant is sometimes just the only option. And this goes for also our cases of cardiomyopathy that we'll talk about, because oftentimes cardiomyopathy leads to heart failure. But we'll talk more about heart transplant here in just a little bit. Other surgical managements then are therapies to reshape the left ventricle to improve hemodynamics. So there's a partial left ventriculectomy, which is where they remove essentially like a triangle from the left ventricle to reduce the diameter and the wall tension. Then there's an endoventricular circular patch cardioplasty. That is where they remove an area of the septum. And then acorn cardiac support device. It is basically what it is. It's a support device that goes around the heart that prevents it from overstretching. So that way it kind of stops that cycle of compensation where it's trying to continually stretch to improve cardiac output. Well, that in turn just increases hypertrophy and causes the vicious cycle. So those support devices help to prevent that overstretch. And then we have our Lvad. So our left ventricular assist devices are an option for severe heart failure patients that either are waiting for a heart transplant or are not a candidate for a heart transplant, and it essentially buys them time before they die. It improves their cardiac function enough to some patients. The last one I had, they'd had an Lvad for like 5 years. So it can really, if they're just either too old, if they don't meet the requirements for a heart transplant, or some patients just don't want one. They don't want to go through. I mean, it is like a mental trauma of sorts that you go, just the process of undergoing the screening and everything that goes along with it, and then knowing that you have to be on all these medications and very specific for the rest of your life. Some patients just choose like, nope, I'd rather have the Lvad and buy myself a couple of years. So I'm gonna play this video. Let me make sure I'm sharing my sound. Okay. This one's only a few minutes.
The heart has 4 muscular pumping chambers: the right atrium, the left atrium, the right ventricle, and the left ventricle. The left ventricle pumps blood out through a large artery called the aorta to supply the body with the oxygen and nutrients it needs. In left-sided heart failure, the left ventricle is not able to pump enough blood to the body. The 2 types of left-handed heart failure are diastolic, where the left ventricle can't relax enough to fill with blood, and more commonly systolic, where the left ventricle can't contract strongly enough to push blood to the body. In severe or end-stage heart failure, the heart is getting weaker and doesn't respond to medication. For left-sided end-stage systolic heart failure, a doctor may recommend an implantable left ventricular assist device, or Lvad, to help the heart pump enough blood to the body. An Lvad is a small mechanical pump implanted inside the chest or abdomen that takes over the job of the weak left ventricle. Blood flows from the left ventricle through an inflow tube to the pump. The pump pushes the blood through an outflow tube into the aorta. From here, the blood travels normally from the aorta to the rest of the body. A cable, called a drive line, connects the Lvad pump inside the chest to a control unit located on the outside of the body. The control unit is a small computer that controls the functions of the pump and alerts the patient if there are any problems. The pump and control unit receive power through a cord connected to a battery pack. Finally, the control unit and battery pack are held in a lightweight patient pack. An Lvad may be a temporary treatment until a heart transplant can be performed. Or, if the patient isn't able to have a heart transplant, an Lvad may be used for destination therapy, which is long-term treatment.
So that is our Lvads. So it truly, I mean, it's amazing. It really is. In the years that I've been a nurse, it's been amazing to see the advancements in this. When I started out, they did not leave the hospital. The Lvad was simply to buy them time until they got a heart transplant. So these patients would sometimes be in the hospital for 6 months they were living at the hospital until they got a heart transplant. Because you didn't go home with an Lvad back when these first, came around. But then now, as you can see, it's a small little lightweight thing, and they can go about their daily life and live, a few more years. So it is really amazing. There's still a lot of considerations that they need to be aware of. They will be on blood thinners for the rest of their life because it's an implanted device that's in the heart. So of course the risk for blood clots is really high. So they have to be very compliant with their blood thinners. They almost always go on Coumadin and not usually like your Eliquis and those things, because they need to monitor their levels very, very closely. And we know that we don't monitor like an INR and stuff with a lot of those newer medications, and the risk for bleeding can be higher because some of those don't have reversal. So they have to be very strict with that. And then, their heart is pumping mechanically. If that loses power, if they run out of their battery and don't charge it and don't have a backup, they have minutes to get that going. So it is definitely not normal, but at least they're not dying and they're not tied to a hospital bed. So there have been now, I just took care of a patient a few months ago that actually had their Lvad removed, and his ejection fraction had improved. And now they didn't remove it completely. They essentially just removed the drive line in that, and still left the internal components in place in case they would need to hook it back up. But he had it for like 5 years, and they do routine echoes and stuff to see how their heart functioning is doing, and his had actually improved enough to where they were able to remove the Lvad. So it's pretty amazing stuff, but there still is a lot of that education that needs to be done, so that way they understand fully what to expect. And the other thing too, it's an external device that, as the video showed, it comes out, through the substernal abdominal region, and it goes to the heart. So they need to be very diligent about skin care and making sure it doesn't get infected, because obviously if anything gets infected or that infection travels to the heart, that can be very, very bad. So they need to be a good candidate for it and are going to be compliant with those things. It amazes me the number of people that come in and because their batteries are dead. They like, oh, I'm from, they're like from across the country. It's like they're just traveling, it's like they know that they only have a couple years maybe to live, and they're just like YOLO. And then like people come from all over just like, oh, I forgot my extra battery pack, and this one's about dead, so I just need to come in and get my Lvad charged. Like, could you imagine? I don't know, I couldn't imagine that, like just being like, yep, oh, it's just keeping me alive, no big deal. But if you were to ever find one of these patients down, like in the grocery store or wherever, or obviously if you take care of them in the hospital, but if you check their pulse, they don't have a pulse, because the Lvad is circulating the blood through it. I mean, the heart barely pumps, because it's so decompensated, it barely pumps to begin with on its own. So you won't feel a pulse. You may possibly feel a very, very thready thrill of a pulse, but more than likely you won't feel a pulse. So as long as you hear that machine running and it's on, you should not perform CPR. The only time you perform CPR on these patients is if you physically see that machine died, it's not on, and you don't hear that pump running. That's the only time you perform CPR on them. And they can be shocked if they go into a lethal rhythm. That's fine. They can be shocked. The other thing is their blood pressure is your automatic blood pressure cuffs. They can't take a blood pressure with these patients because there's no like systolic and diastolic. It's just a systolic. So you have to get their blood pressure manually with a Doppler, and you just get the one number reading. So some different considerations to just to know if you're ever caring for a patient with an Lvad. So pulmonary edema then. So I briefly touched on this with our complications of heart failure, but our pulmonary edema is a big one. If the patient has crackles in their lung bases, dyspnea at rest, disorientation and confusion, those can be some early signs of pulmonary edema. So you really want to be documenting those level of crackles frequently. So making sure, if you know that they have a history of heart failure and they're in with heart failure, and you really want to be assessing those breath sounds a little bit more frequently than even your average med-surg or tele patient. Because if you hear those level of crackles starting to rise, like maybe your morning assessment, it's just in the bases, but then a couple hours later you check and it's more in the mid lobes, that should start cueing you in like, okay, this is potentially getting worse and we don't want it to progress. And then anxiety, tachycardia, struggling for air, their low O2 stats. Then they start getting a moist, frothy, blood-tinged sputum, cold, clammy, cyanotic. That feeling of impending doom is often what happens. But if they're getting to the point where they have that moist cough and frothy, blood-tinged sputum, it's up there high. They're drowning at this point. And it is rather terrifying, these patients that progresses to especially flash pulmonary edema, because sometimes it happens so quickly you just can't even catch it before they're needing to be intubated. And when these patients get intubated, you need to stand back, because oftentimes if they cough after that ET tube is in place, I mean, that frothy sputum just comes pouring out the ET tube. So getting those rapid acting diuretics on is key with these patients. So Lasix, large doses of Lasix, 80, 100 milligrams IV push, oxygen, and high Fowler's position, getting them up, trying to get them to cough and get those secretions out, even though most of the time they can't. Morphine can be given as well. So morphine helps decrease those circulating catecholamines and helps decrease their preload and afterload, which then helps in turn with that pulmonary edema and decreasing the pulmonary workload. Nitroglycerin IV as well helps decrease that oxygen demand, and a Foley catheter if they let you. But usually if you're going to be giving those massive amounts of diuretics, then you're going to need a Foley, because you need to measure that urine output adequately, and you don't want them to retain a bunch of that urine either. So they'll usually get a catheter at this point. And as far as our diuretics, usually furosemide is going to be our main one, but it is possible they might do bumetanide, tends to be given more so with some of our renal failure patients. But either could be a potential option, but furosemide tends to be the first drug of choice when it comes to those rapid acting ones. So here we have a case study. We have the nurse admits Mrs. C, an 81-year-old client, to the intensive care unit. Mrs. C, who has a history of mitral valve regurgitation and left ventricular failure, came to the emergency department with symptoms of increasing shortness of breath over the past week. The client received furosemide, 100 milligrams IV in the ED, and she's receiving oxygen via nasal cannula at 4 liters a minute. When Mrs. C arrives in the ICU, she is sitting up in bed at 60-degree angle. She is pale with circumoral cyanosis. Her respirations are labored and rapid. She indicates that she feels very short of breath. Okay, so what's our urgency here?
Pulmonary edema.
Yeah, pulmonary edema. I mean, that's a giveaway because we just talked about it, right? But what's her past medical history that indicates that it's likely pulmonary edema?
The left ventricular failure.
Mm-hmm. Left ventricular failure. She's got valve problems too, which you'll read about or listen to the thing often causes as well are, valve problems can cause AFib also, which we know AFib can decrease cardiac output, which if it's chronic can lead to CHF. But just with the regurgitation and not allowing, the heart to pump enough cardiac output adequately can also lead to that ventricular failure. Okay. So what was the next slide? So when the nurse assesses Ms. C, she has crackles audible throughout both lung fields, coughing up pink frothy sputum. Oxygen is 85% at the 4 liters per nasal cannula. Respiratory rate is 38. She's got 3 to 4 plus pitting edema in her feet and up to her mid-calf. Pulse is 115. Blood pressure is 165/99. BNP was obtained and noted to be 875. With the head of bed elevated to 75 degrees, the jugular veins are distended up to the jawline. All right, so we've got a lot of information here, but what is some additional information that we might want to look up? What else do we want to know?
Her kidney function?
Yes, kidney function. We need to know what her kidney function is. So going along with the kidney function, what else do we want to know that we haven't documented or assessed yet? Let me go back to the other. What was it?
I said output, but I don't know if that.
Yeah, output. So she got Lasix in the ED, and clearly she's still getting worse. She's not getting any better. So we want to know her kidney function, and we want to know what her output is. Like, is she able? Is that diuretic even working for her? If it's not working, we might need to be thinking of something else, like maybe that Nesteride or something that's going to improve her contractility and maybe help get fluid off that way, or maybe she's retaining, maybe she might have some output, but she's just retaining and we need to put a Foley in. Yeah, so her renal function is always important when we're giving diuretics, because it can greatly affect the effectiveness of how well it'll be. Yeah, so what are we likely going to wind up doing to her?
Intubating.
Yeah, she's probably going to get intubated, and then at least then can remove the fluid that continually fills up, by suctioning, and then try and figure out something else if that Lasix isn't working. Yep. Good. All right, so now we have cardiomyopathy. Cardiomyopathy is a subacute or chronic disease of the cardiac muscle. So it is classified into 4 categories based on their abnormalities in the structure and function. We have dilated cardiomyopathy, hypertrophic, restrictive, arrhythmogenic right ventricular cardiomyopathy. And as I already mentioned, cardiomyopathy often leads to heart failure. Dilated cardiomyopathy is the most common cardiomyopathy. It's where both ventricles are dilated, but the ventricular wall thickness is normal. The cardiac output is decreased because it can't pump adequately. Often causes of this: alcohol abuse, chemo, infection, inflammation, poor nutrition are often causes. And then with our hypertrophic cardiomyopathy, it's characterized by asymmetric ventricular hypertrophy and disarray of the myocardial fibers. So that left ventricle hypertrophies and leads to a stiff ventricle. Some people don't have any symptoms with it, and then others have syncope, palpitations, dyspnea on exertion. So because that left ventricular wall is hypertrophied, it causes the chambers to be much smaller too. So it can't get adequate output because the chambers can't fill enough, and that ventricle is just too hypertrophied. And this often can cause sudden cardiac death and ventricular dysrhythmias with this hypertrophic cardiomyopathy. Restrictive cardiomyopathy is the rarest. It's again has stiff ventricles that restrict filling during diastole, but symptoms are similar. That should say left or right heart failure or both. A lot of the cardiomyopathies are going to have symptoms similar to heart failure though, because they're just similar. And it can lead to both left and right heart failure as well, especially the dilated cardiomyopathy where both sides of the heart are affected already. And then there's arrhythmogenic right ventricular cardiomyopathy. That results from the replacement of myocardial tissue with fibrous and fatty disease. It's often familial associated and affects young adults more often. Some have no symptoms and others do, and they can have left ventricular involvement as well. Even though it's right ventricular cardiomyopathy, they can potentially have that left ventricular involvement as well. So intervention.
And that last one, can that cause, say, hypothetically, a 19-year-old to literally like drop dead?
Yes, it can.
And it's not caught like throughout all their well child checks and all that?
Yeah, it could potentially, yes.
Correct.
Cardiomyopathy is one of those things that, yeah, sometimes you hear of people getting diagnosed with it like later to realize that it was likely congenital. And also cardiomyopathy can occur can be like pregnancy induced with the dilated cardiomyopathy. So if you've ever heard of like women like going into heart failure after pregnancy, it's often a result of a type of cardiomyopathy that they need a heart transplant for. So there's been, at least 2 or 3 in the last several years that I've known at Lutheran anyway, that wound up needing a heart transplant after childbirth because the pregnancy in general, for whatever reason, I don't know if it has a congenital thing that maybe these women that they didn't know about as well. I don't know the exact reasons and stuff why that happens, but it does.
Do you know what other like risk factors in pregnancy might have been that led to that? Like if they had preeclampsia or something?
I don't see. Even though I work in the cardiovascular ICU, I float there, I don't take care of the heart transplants because you have to have like the whole big old special training. And since I'm a float nurse, they only do that for the specific CVIC nurses. So I didn't know like their whole stories to know like what other like factors they had. I do know one did have congenital heart problems, was basically told she should never get pregnant, did anyway, and had like 3 kids. And it just like trashed her heart more and more each time. And then she did wind up getting a heart transplant, and then she got pregnant again. That wasn't a good situation. But yeah, I don't know the full story of a lot of them and what other factors come into play with a lot of that stuff, unfortunately.
I'm just curious. Thanks.
No problem. So intervention. So with dilated cardiomyopathy, again, we're going to treat it a lot like heart failure. If they develop if it's from a result from a toxin, of course, we're going to avoid or remove that toxin. Hypertrophic cardiomyopathy is going to be treated with beta blockers and calcium channel blockers. So your negative inotropic agents. The negative inotropic agents weaken essentially the force of contraction and with hypertrophic cardiomyopathy, you don't want anything that's going to strengthen it because the heart is already like too bulked up. So we don't want to do anything that's going to worsen that. So you're going to avoid vasodilators, diuretics, your nitrates, cardiac glycosides, because they have a vasodilating and positive inotropic effect. So we don't want to give anything that's going to like try to over contract and overstimulate that already over hypertrophied heart. So we're going to give our negative inotropes with those type of patients. And then heart transplants. So with our, hang on. Excuse me. Oh, and with our vasodilators too, those decrease preload. And we don't want to do anything that's going to decrease preload because that's going to decrease filling. Well, those ventricles are already small because of the hypertrophy. So we don't want to decrease the already small fillings. All right, so heart transplant then. So our heart transplant is our big, obviously curative treatment for severe cardiomyopathy or severe CHF. We remove the old heart and put in a new one, right? We know what a heart transplant is, but with our heart transplant, there's a lot of factors that we need to take into consideration. So of course, bleeding is going to be a big thing. Bleeding into the pericardial sac that then can cause cardiac tamponade. If that heart can't beat, it's going to be restricted and it's going to cause an emergent cardiac tamponade situation. The other thing is that the transplanted heart is denervated and it's unresponsive to vagal stimulation. So because that like vagus nerve is cut essentially in removing the old heart and putting the new one in, they don't have the same response to certain medications like atropine and DIG. They don't have the normal effects of that because it stimulates and helps, it has an effect with that vagus nerve that they no longer have. It's denervated. So isopril is going to be used instead of atropine because it works on different pathways. And they could potentially have a permanent pacemaker. Again, if anything in the pathways gets damaged, they could have now an underlying heart rhythm of asystole. So if they'll come back from heart surgery with a temporary pacemaker, and what they generally do is just kind of turn off that pacemaker intermittently to see what their underlying rhythm is. And if they either A, don't have an underlying rhythm anymore, or B, or have like a severe heart block, complete heart block, something like that that's causing severe bradycardia, then they're likely going to wind up with a pacemaker as well. And it could have the pacemaker, even if it's a permanent pacemaker, to just help improve their cardiac output, to get their heart to beat more efficiently. That might be an option as well. You're going to instruct them to change position slowly, again, because that heart is denervated and they don't have the same effects as our patients with a normal heart. They can get dizzy and lightheaded a lot faster. Using those immunosuppressant therapies for the rest of their life is a big thing. They need, I mean, beforehand, even before they get, it's not like this is all stuff you're going to spring on them after a heart transplant. This is all stuff that they need to know before, ahead of time, with lots of education to truly understand everything that's going to be involved with after they have a heart transplant, that they have to be very, very compliant with their immunosuppressants. Otherwise, they could reject that heart. And we all know hearts aren't easy to come by, so they need to be very compliant and understand that this is what you have to do for the rest of your life. So if they're on those immunosuppressants, again, those things that we normally teach patients if they have a depressed immune system, washing their hands, watching for infection, avoiding sick people, avoiding big crowds, all those things that they need to make sure they're understanding. I think that was it with the heart transplant. Yeah. So next complication, our thromboembolism, or our VTE. Where are we at? Okay. I'll be able to finish this section and then we'll take a break. All right. So then our thromboembolism, our VTE, our thrombus is a blood clot that's result from endothelial injury, venous stasis, or hypercoagulability oftentimes. But our main one is our DVT. So our DVT, our main treatment is resting and elevating the legs, heparin or our Lovenox or enoxaparin, our low molecular weight heparin, warfarin, thrombolytic therapy. So with our heparin and our warfarin, is that going to dissolve the current clots?
I heard no.
No, it's not going to. We treat them with that because if they already have a DVT, they're at risk for developing another one. So we get them started on that as soon as possible to try and prevent any other clots from forming, but it's not going to dissolve the current clots that are there. Our thrombolytic therapy is what dissolves clots. Thrombolytics are our clot busters. So if it's a large enough clot, they might go in locally, like through a heart, or well, not a heart cath, but a catheter, like through interventional radiology, and they can go to where that clot's at and administer that thrombolytic directly to the clot. If it's large enough, or if they feel, you know, it's something that that patient really truly needs, that is what they could do. So sometimes they'll go in, administer the thrombolytic, and then they'll have like a continuous infusion that goes in over like 24 hours directly in the leg where the clot's located, and you as a nurse are monitoring it. So that is one option. And then we also have our novel oral anticoagulants. So that's our newer, a lot of those newer drugs that are out now. But again, some of there's pros and cons. The pros is they don't have to have those bi-weekly, or not bi-weekly, you know, a few times a week blood draws like you do with Coumadin to check their levels. They just stay on a consistent amount, and they don't have to have those blood checks. But the downfall is some of them don't have a reversal agent, and the only option is like the fresh frozen plasma if they come in with any type of bleed, either a GI bleed or a head bleed, anything like that that can occur spontaneously. So they are, I don't know, I feel like they're a little bit more risky, but it really just depends on the patient and the physician that's just discussing their best options. And then you're going to monitor for signs and symptoms of PE. We know that leg clots in the legs will travel to the lungs. Again, as I mentioned earlier, legs go to lungs, heart goes to the head. So they're at risk for PE if they have DVT. So those monitoring for those signs and symptoms. So shortness of breath, that sudden feeling of impending doom, decreased oxygenation, diaphoretic, all those things that could be a result if they develop a PE. And then it is possible then that they might decide that they're a candidate for an Ivc filter to prevent PEs from occurring. So sometimes they'll place an Ivc filter, an inferior vena cava filter, if they can't be on blood thinners for whatever reason, but they don't want to risk them getting a PE and, you know, have it become life-threatening. So when we're looking at a patient who potentially might have a DVT, what are some signs and symptoms that they might have one?
Absent pulses in the lower.
Mm-hmm. Yeah, if it's severe enough, they could have absent distal pulses.
One leg bigger than the other, redness, warmth.
Mm-hmm. Yeah. Yep. So that's our biggest indicator that we're looking for first is the red, warm, swollen calf. Usually, I mean, it can be anywhere in the leg, but it tends to be where the calf seems to be the most common, or in that area, like the popliteal and stuff as well. What's something that we don't check anymore? Which maybe you guys don't even learn about it anymore.
Isn't it like Homan sign?
Yeah, Homan sign. Homan sign is really not best practice. It's not a definitive diagnostic tool. And two, if you're making the patient move their leg like that, depending on where their clot is, it could just cause the clot to dislodge. So we don't do Homan sign anymore. We go by symptoms of, you know, just the pain, swelling, redness, warmth, all those things. And then of course, an ultrasound would be our definitive diagnostic tool to see if they have a clot there. So here's your Ivc filter. Right there is where it sits in the inferior vena cava. And it just, if the patient happens to have any clots, it collects it before it goes up and goes into the lungs. Then we have pericarditis. Pericarditis is swelling and inflammation of the pericardial membrane. So with pericarditis, they'll start to complain of substernal precordial pain. It can radiate to the left side of the neck, shoulder, or back.
Okay. Oh,
Yes.
sorry.
It's okay. And they can have grating, stabbing, oppressive pain. It can be aggravated by breathing, coughing, swallowing. So having some of those symptoms, like the breathing, coughing, swallowing, that, you know, might signal that it could be a PE, but that will tell us more. So if it's more aggravated by things, then you know it's not like a true chest pain, like a MI type of chest pain. And then the pain can be worsened by supine position, and it's more relieved by sitting up and leaning forward. So it just kind of helps get the pressure off that pericardial region. And with pericarditis, so it's
Quick
often,
question.
yeah.
The sitting up and leaning forward, would we call that tripod?
Yeah, essentially, it's just not quite
I'm
as
just thinking it would help me
exaggerated.
remember to like,
Yeah,
'cause that's,
I mean, you can remember it that way. It's just not quite as exact. It doesn't need, those patients don't usually need to be quite as exaggerated as like your COPD patients do.
gotcha.
Just enough to kind of help like relieve the pressure, because when it's when they're laying back, it puts more pressure on that pericardial sac, especially for like a woman or something that has breast tissue, that can apply pressure on it. So with pericarditis, it often is a complication, can be a complication after like heart surgery and stuff as well. It is possible they could have infection of the pericardial sac too. But if you know that they have a diagnosis of pericarditis and they are complaining of chest pain, that would be like one situation where we know normally that chest pain is an emergent situation. Like, oh, okay, we gotta do something. Either it could be a PE or an MI. We gotta do something. But if they've already got a diagnosis of pericarditis, chest pain would be normal for that patient. So it's not that would be one of those situations where it's not an emergency situation. So knowing those things are important, that if they've already got that diagnosis. Then we have pericardial effusions and cardiac tamponade. So your pericardial effusions can lead to a cardiac tamponade if it's severe enough. But our effusions itself are an accumulation of fluid in the pericardial sac. And our pericardial sac normally contains 20 milliliters of fluid in order to decrease friction on the beating heart. So with a pericardial effusion, it'll elevate pressures in all the cardiac chambers, will decrease venous return, and then starts to cause the inability of the ventricles to distend and fill. So we talked about this last week when we talked about PEA, that cardiac tamponade can be a result, or PEA can be a result of cardiac tamponade, because the ventricles, or the heart itself, still has the electrical activity going through it, but it no longer can beat. So they will have a rhythm without a pulse. So it's an emergent situation and needs to be corrected as soon as possible. So pericardiocentesis is often the quickest method to relieve that fluid, where they just go in and do like a needle aspiration and remove the fluid to get the heart to start beating again, and then try and figure out, A, are they bleeding, or B, is it from, fluid? So correcting the problem before it recurs. Or a pericardiotomy. Your pericardiotomy then is where they would go in, not just a needle aspiration, but open up, sometimes like a pericardial window, or they open up the patient and go in that way. Sometimes if it's after a heart surgery, they might just crack the chest back open and relieve it that way. So different options depending on what the underlying problem is. So the signs and symptoms though, yes?
What typically, like, how much do they typically remove when they do something like that?
That's a good question. I don't know, to be honest. I'm not sure how much. I mean, it doesn't take much. I know that. It's not going to be like how with your thoracentesis or your paracentesis, where you can remove like liters, but because it's only 20 milliliters that is in that sac to begin with. But I don't know. I really don't know how much it would typically take. It would also depend on how, because some patients have cardiomegaly. If they have a larger heart to begin with, it would probably take a lot less for those patients. But yeah, I don't know. I'd have to look.
So they can do it, like they can remove the fluid around the lungs too then?
Yep. Yeah. Yep. We'll talk more about thoracentesis in the respiratory section, but yep. If
Because
there's
I had
fluid,
a friend, like, and I know this was like years ago, so I don't really remember the details, but she went into heart failure after her pregnancy, but
Mhm.
then they had to remove fluid, and I think it was around her lungs, and she had like liters removed.
Yeah. Yep. You
after.
definitely can, especially, I mean, with heart failure, things can back up and cause fluids to accumulate, around the lungs, around the body, everywhere. So yeah, that's not uncommon either. And yeah, you can remove liters from the lungs as well. Like not as much as you can remove from the abdomen, but yeah, I've seen patients have a couple of liters removed from their lungs. Maybe like 1,500 from one side and like, another 1,500 from the other. But yeah, you definitely can.
Okay.
With your cardiac tamponade, the signs and symptoms that you'll see is obviously signs and symptoms of decreased cardiac output because the heart's not able to pump. But some of the other big things, so those things like your syncope, dyspnea, shortness of breath, those type of things. But then also you're going to start hearing muffled heart sounds because it's not beating the way it should. They'll have distended neck veins, so they'll have that JVD, but without fluid. So usually, we see JVD with like edema and stuff like that, fluid overload, but they'll start getting JVD without any other signs and symptoms of fluid overload. And then they'll have a paradoxical pulse. So paradoxical pulse is when you have a elevation in your blood pressure on expiration. So you would need an arterial line in order to judge that because it's going to be too difficult to do like a manual pressure right on expiration because we know how short expiration is and we know how long it takes sometimes for those blood pressure cuffs to give a reading. So you'd really, to adequately do it, you would need a arterial line to see if they have that. It's about 10 millimeter fluctuation in their blood pressure, 10 millimeter rise in their blood pressure on expiration. So that's another sign that they could be developing some cardiac tamponade. And that was it. Okay, where are we at with time? Okay, so let's take 15 minutes. Let's be back at right around 10:20. Yeah, about 10:20. And we will move on with MI, the ACS MI stuff. Before we get started on the angina and MI and all that stuff, I just want to kind of go over briefly a few highlights with the valves and aneurysms. So when you're going through those PowerPoints and the valves, I mean, very basically, we know that stenosis is hardening or stiffening of the valves, and regurgitation is loose or the backflow of the valves. Doesn't matter which valve is affected, stenosis is hardening and stiffening, regurgitation is loose backflow. Doesn't matter what type of valve. But primarily your mitral valve problems are going can cause both right and left heart failure. Usually starts with right, but then your aortic problems is almost always going to be your left heart failure with your left ventricle, with it being the aorta. So generally speaking, that's what you will see with those different types of valves. So when I've mentioned that I talked about heart failure and everything, but when we refer to heart failure for this exam, it's going to be more so related to the problems associated with it as opposed to specifically heart failure. And our valve problems often wind up having AFib. With those valvular heart problems, those patients are more at risk for developing AFib. So then there's all those risk factors that go along with AFib as well. So really the heart is just a cascading effect of one problem can really just start to cascade and lead to multiple problems when you're looking at the big picture of cardiac output. Then with your treatment with your valves, with the valve replacements and all that. We're going to talk about our CAB, or open heart surgery, cardiopulmonary artery bypass. So with that today, a lot post-op wise is going to be the same as your CAB patients, because they're still going to have the open sternotomy and have the same post-op restrictions as you do with your any open heart surgery. With the exception with your valves, they really need to avoid dental procedures afterwards, because of the risk of that bacteria and stuff that can become dislodged in the teeth, and the dental caries and stuff can, for whatever reason, can travel to the heart. And the valves in particular, if they have a mechanical valve, they tend to be more at risk for developing the what's the word I'm looking for? Vegetation. They can grow vegetation as a result of poor dental hygiene, or if they have those procedures and it becomes dislodged. So they shouldn't have any dental procedures for at least 6 months after valve replacements. And they're almost always going to have some type of antibiotic prophylactic even prior to those procedures as well. So with that, well, that's the main, and that's, you know, really a lot of the main things with your aneurysms. Just go over the PowerPoints, listen to that, and focus on those areas as far as teaching and that sort of thing. And then with your aneurysms, same thing. Don't go like overly deep with them. Just knowing what your AAA is the main thing that I discuss, is your abdominal aortic aneurysm. Knowing what it is, the signs and symptoms, and how we're going to treat it. And there's a difference between your signs and symptoms of just your typical AAA and then a ruptured AAA, because of course a ruptured AAA is definitely going to be more emergent and be more severe. So those are the things I want you guys to focus on when you're studying up on that stuff. Okay, so now we are going to start with our angina with RMI. All right, angina pectoris, or angina, I don't know. I say angina. You hear people say both things. So however you want to say it, up to you. All right, so we have our different types of angina. We have our stable angina, unstable angina, variant, silent, or our silent ischemia. So with these, as the name implies, stable is stable. It's predictable. You know that if you start having chest pain and you relax or sit down or rest or take a nitro, it's going to go away. It's stable. So with that, those patients tend to have more of a plaque buildup issue, where there is something that's causing, you know, with either activity, exertion, something's decreasing the amount of oxygenation that the heart is getting, but we can correct it without, you know, extreme measures. So it's predictable, it's consistent. They know what can fix it, essentially. But then when we go into our unstable then is now more unpredictable. It can occur at rest. It's not relieved by rest. It generally lasts longer than 15 minutes, upwards of 30 minutes. But your stable is going to be less than 15 minutes. It can be reverted and pain-free in less than 15 minutes with one of those interventions of rest or nitrates. But your unstable will not. It will last longer than 15 minutes, and it's not typically relieved by rest. And the other thing with unstable is that it may or may not be relieved by nitro. And unstable can also be a precursor for an MI. Unstable is the one that you really want to get a hold of quickly before it turns into the main event. So with your unstable, if they're taking nitro and it's not relieved by, if their chest pain is not relieved by the nitro, they should be calling the medics, because it could be resulting into a full-blown MI. Their troponin could still be negative at this point. So in your unstable, it's ischemia is present, but it's not significant enough yet that causes cell damage or death. Then you have variant or Prinzmetal. It can be unstable in nature. It is a result of a vasospasm. So with your variant angina, it has, you know, there's the coronary artery that's being affected is spasming. Yeah. Hello? Did somebody say something?
Are we supposed to be seeing a PowerPoint on the screen?
Oh, yeah, you are. Did I not share? Hang on.
No, sorry. I was like, wait, what are you
Just a minute. Let me go back up. I mean, you're not missing much. It's just the first one. Where is my share button? Let's try this again. Okay. Oh, there you go. Sorry about that. Thank you. So again, with your variant, it's going to be a result of a spasm. They could have ST segment elevation during that spasm, but if you happen to do an EKG when that coronary artery is not spasming, the ST segment will usually not be elevated. So it may or may not be relieved by nitrates, but often it's not because it's spasming. There's not a lot that can be done other than wait for the spasm to pass. So it can lead to a full-blown MI. They can have, if it's severe enough, an MI and elevated troponins. But the thing with your variant is that it's not something that's necessarily needs corrected with like a stent or something, because there's no true blockage that needs opened up. I actually had a student a couple of years back that had, he was only 27 and he was a relatively healthy guy, but it can be caused by stress and tobacco, alcohol, lots of factors can affect it, but it's not a true like blockage. So he didn't need a stent or anything, but it was severe enough that it did cause him to have an MI. But things were reversible, and they just got him on medications to help prevent further spasming from occurring and trying to figure out what the underlying problem was. So that, again, it's not your typical type of MI patient. And then with your silent ischemia, that's the type of patient that is getting a routine, maybe they're going for a hip surgery or hip replacement, but they're getting their routine cardiac workup done to make sure they're suitable for surgery. And then they find out, oh, their EKG is showing some ischemia, and their stress test is showing that they could potentially have some blockages. They go in, do a heart cath, and what do you know? They need some stents to some blocked areas, but they weren't having any pain at all to begin with. So that one can be a little bit scary if you're not having any pain, and it can just be, you know, a silent MI. So those are just the main differences between the different types of angina. Associated symptoms then are typical chest pain, you know, substernal chest pain radiating to the left shoulder, the left jaw. Those areas can go radiate to the back, you know, subscapular. But there are certain patient populations that don't have those typical associated symptoms as well, or at least not the typical pain. Your diabetics tend to have more atypical symptoms because of neuropathy and that. And then women, for whatever reason, have more diffuse symptoms, more generic, and the elderly tend to have not your typical symptoms either because of their decreased neurotransmitter responses. But nausea and vomiting, shortness of breath, diaphoresis, weakness, dizziness, or potentially none. So all those though are potential, if you wrap it back around to cardiac output, those are all typical symptoms of if you start having decreased cardiac output that you're going to experience. So patients having an MI are going to have signs of decreased cardiac output. You know, they're not oxygenating their body, their brain, the way that it should be. So they're going to start having those associated symptoms. So when we're diagnosing an H&P, knowing when has the pain been relieved at all. If it's relieved within 30 minutes, it's usually unstable angina. If it's less than 15 minutes, it's going to be stable. Does the EKG show any ST segment elevation? If there's no ST segment elevation, then they are not having a STEMI or ST elevated MI. Cardiac enzymes, our troponin is going to be our big one. Our troponin is like our gold standard for diagnosing an MI. If it's elevated, which above 0.03 would be considered an elevated troponin. There's a new troponin that's coming out that I've seen things for, at least that at Lutheran. So it might be at Parkview too, but it's like a troponin next generation or something. It's a different type of troponin, and the level is like completely different. It's like 10,000 or something. So for this test though, we're going by our typical troponin I, which should be less than 0.03. And then a stress test, that can show potentially if there's any blockages or areas that are being affected. And then our most diagnostic would be our heart cath with angiography, going in, looking at the heart and finding where the blockages are. Our pharmacological management. So again, you have a lot of these on your handouts. Our nitrates, we know that nitro, sublingual especially, is going to be kind of our go-to for any type of chest pain. It helps decrease our oxygen consumption. It's a vasodilator, decreases that oxygen demand and consumption, and in turn helps decrease pain. If the heart isn't demanding as much oxygen, then it's going to decrease that pain. Beta blockers also help decrease oxygen consumption and also help relax the heart to help improve pain as well. Calcium channel blockers, that decreases our ventricular response. So our calcium channel blockers, if it's a tachycardia of some sort, if it's caused by that, that will help lower the rate by decreasing the amount of responses that are going through the AV node to the ventricles, and it helps relax the blood vessels as well. Aspirin, we know aspirin, it's our platelet aggregator, helps prevent blood clots. And with aspirin, that's something that's important that they need to get on board right away. So when your patient comes in with chest pain, we know that nitro and aspirin are kind of like our big things, right? But aspirin is super important. That 4 baby aspirin that they chew needs to get on board right away. And if you think about it, so aspirin they can take and they need to chew it to have that rapid acting response to it. And then you give the nitro because it's sublingual, you give it once every 5 minutes and stack them until the pain's gone, right? So if you give the nitro, it's kind of hard to give the aspirin right after the nitro because that needs to sit in there and dissolve, and they're not going to want to be chewing aspirin and then swallowing it. So generally, not only is it best practice to get the aspirin on board right away, it just makes more sense too. And then Plavix potentially as well for that platelet that works on different pathways than aspirin does for that platelet aggregation. And they'll often be on Plavix if they're have stents placed or some sort to help prevent that platelet aggregation on the stents themselves. Heparin, again, well, it's not going to dissolve any current clots or any problems that are going on, but it will prevent further problems of clots from occurring. Our glycoprotein 2B and 2A antigens, so those are given IV and usually used after they've had a stent placement. They'll have that on board for 24 hours or so until the Plavix has time to take effect. So they kind of give a loading dose of Plavix, start them on the IV glycoprotein, and then they'll take them off the IV form and just continue with daily doses of Plavix. The other thing with your nitrates, so we know that we give it stacked. We give it once every 5 minutes times 3, sublingual or spray, depending on what type is at your facility. But what are some things that we need to be aware of with our nitrates that we need to monitor or know, just in general? See, I ask questions so I can stop and sip my coffee for a second.
Blood pressure?
What's that?
Blood pressure?
Yeah, blood pressure, right? So our nitro is going to drop our blood pressure significantly. So if they tank after that first one, you don't want to give a second one and like make their blood pressure go down to like 40. So you got to be careful with your nitro, making sure you're checking the blood pressure. Yeah. So, and then also nitro, if they're, a stable angina patient that's going home with nitro and they're taking their nitro tablets, something big that patients always forget or maybe think it's not a big deal is the expiration date. If they're taking their nitro and it's not doing anything, they should probably be checking the expiration date because it's only good for about 6 months to a year, maybe depending on the type. But usually there's going to be an expiration date, and nitro is definitely one of those things that if it's not or if it's expired, it's not going to work adequately. So sometimes you'll have patients come in like, oh, I took 3 nitro, it didn't do anything. And then they take a nitro at the hospital and it worked just fine. And then they've got it in their pocket and you look at it and like, oh, well, it's 4 years old. That's why it didn't work. So that's important to make sure you're educating them on those things. And then with the beta blockers, oh yeah, and what's another med that you need to know that they're on if you're going to give them nitro?
ED meds.
Yeah, the ED meds, because those can, in combination with the nitrates, can really drop their blood pressure too. I had a patient that came into the ED with chest pain and he was like 85. And he was there with his wife. And, you know, that was one of the questions that the doctor asked. And he was like super embarrassed to admit that he had just taken one a couple hours ago. And it was so cute and disgusting at the same time. But yeah, you need to ask them about those things. And then we have our beta blockers. So some education or things to be mindful with your beta blockers. I already talked about the cardio-selective versus non-cardio-selective, so making sure you know that. But also, if they are diabetic, beta blockers can mask hypoglycemia. So making sure that they're aware of those things, and you're aware of it, checking blood sugars and stuff as well. And if they stop their beta blocker abruptly, if they're taking it for chest pain prevention to help with stable angina, if they take it or run out and they quit taking it, it can cause sudden severe chest pain if they suddenly just stop taking it. So they need to be aware of those things as well. All right, so then our ACS and our MI. So our acute coronary syndrome, it's an emergent situation characterized by an acute onset of myocardial ischemia that results in myocardial death if definitive interventions do not occur promptly. So we know, we've heard it before, that time is muscle, right? So the spectrum includes unstable angina, because like I mentioned, it can be the effects or the precursor to an MI. Non-ST segment elevated MI and ST segment elevated MI. So our ST segment elevated MI, that's our STEMI. So with the myocardial infarction, an area of the myocardium is permanently destroyed. So usually a plaque buildup, it could potentially be a clot, but it's most commonly plaque that either breaks off and occludes, or just a complete blockage that eventually occurs. So it's blocking blood flow and oxygen to that area of the heart. So when you look here at this vessel that has been blocked, this whole branch down here that is your RCA, your right coronary artery, is no longer giving blood and oxygen to this area of the heart and results in destruction. So the plaque ruptures, a thrombus forms, there's a complete occlusion of the vessel, and it can be caused by vasospasm with an increased need for oxygen. So if for whatever reason those spasm, it can block off that area as well. So presenting symptoms. Again, decreased cardiac output. You're going to have symptoms of decreased cardiac output. So cardiovascular, the chest pain that's unrelieved by rest or nitro, jugular vein distension, elevated blood pressure, irregular pulse and dysrhythmias, respiratory, they can have shortness of breath, tachypnea, crackles, GI, nausea and vomiting, GU, possible decreased urinary output if the cardiac output is severe enough that it's decreasing the kidney perfusion, skin that's cool, clammy, diaphoretic, and pale, neurologic, anxiety, restlessness, and then that fear and impending doom as well. Sometimes if they have some more GI symptoms, the epigastric pain, nausea, vomiting, they'll still treat it as an MI, but then also they might potentially give something that's called a GI cocktail. Gives like some medication that helps with acid because acid reflux can be severe enough that it can feel like chest pain and just be bad. So some patients it's just that severe that then they take that GI cocktail and it's got a little bit of lidocaine in it too that numbs like the esophageal lining and stops the pain. So that's usually a good indicator, like, okay, I think it's GI related and not actually heart related. But the big thing is that it's going to be over 30 minutes. So if they're still having pain and all that, that's not relieved by anything, and it's lasting longer than 30 minutes, that's a big indicator that it's an MI. So our diagnostic findings are going to be based on the presenting symptoms and our cardiac enzymes and biomarkers. So that will clarify if the patient has unstable angina, non-STEMI, or a STEMI. So if the troponin is elevated, it is likely it's an MI. Now, there are certain situations where troponin could be elevated slightly, just a little over that 0.03, and it's a result of something else. But generally speaking, if they have all of these other presenting symptoms, it's a result of an MI. Unstable angina may or may not have elevated troponins at this point, but your non-STEMIs and your STEMI will. And then on your CKMB will be elevated as well, but they are not cardiac specific. Your troponin is your one that is specific to your cardiac muscle. Your CKMB can be elevated for other factors as well. So if they're elevated, but your troponin is not, that would be an indicator that it's not MI related. And then our 12-lead EKG. So then our 12-lead EKG is going to tell us whether it's a non-STEMI or a STEMI. You know, our enzymes will tell us if it's an MI or not, but then our 12-lead is going to tell us what type. So then that is where we start looking at our ST segment. So with our ST segment, there needs to be elevation of at least 1 millimeter in at least 2 contiguous leads. So what that means is that ST elevation, so you'll have this rise above the isoelectric line, above that line that's level with the PR interval. And it has to be in 2 contiguous, not 2 leads, not 2 leads side by side, but 2 contiguous, which means it has to be 2 leads that are affecting the same side of the heart. So it has to be in the same side of the heart in order to be classified as a true STEMI. So when we look here, I'm gonna look here. So here is where we see the leads that are associated with which part of the heart. We have our septal, anterior, lateral, and inferior. So 2 contiguous leads means 2 leads of the same heart. So it has to be 2 septal leads or 2 anterior leads or 2 left lateral or 2 inferior. It cannot be one of each or something. It has to be the same part of the heart in order to be classified as a true STEMI. So if you have leads elevate or ST segment elevation in leads V1 and V2, it can be both a septal and anterior MI. Now we'll talk about that here in a second. Well, here first, T-wave inversion often can indicate ischemia. Our ST segments are a big one that shows injury right now. An infarcted Q wave, so a widened QRS or like a notch in the QRS can show a previous, sometimes patients have that after they've had an MI, can show a previous MI, but our ST segment elevation is what we're really looking for closely. So when we look at the different areas of the heart, we need to look at the coronary arteries that are supplied or that are supplying that part of the heart. So when you look right here, you have your right coronary artery. So your right coronary artery is starts off right in this area, what is right here? What is being supplied right here by our right coronary artery?
The SA node.
Mm-hmm. Yep, the SA node, the right ventricle, or the right atria, right? So the right atria is there, and our SA node is in our right atria. So if there's a blockage in that right coronary artery, the SA node is not being supplied. So what type of problems would you see with someone who has a blockage in their right coronary artery? What would you expect to find?
Low heart rate.
Yeah, so you're going to have more atrial problems, right? They could have bradycardia or tachycardia, blocks, your heart blocks, AFib, aflutter. You're going to have more of those problems that are associated with the SA node. Right. So now if you have a blockage in your left coronary artery, so right up here is your main left coronary artery or your left main. The other thing that you sometimes hear it called is the widowmaker. So this is the artery that can cause sudden cardiac death. And if you look here, if you have a blockage way up here in your left coronary artery, look at everything it supplies. Your left main supplies your left anterior descending, and your circumflex, which is basically your entire left side of your heart, right? So that's, I mean, which is right here. What is right here? That is like the main part of our heart that we need.
Left
We need, yeah, our left ventricle. I mean, we need our whole heart, but especially our left ventricle. So if it's not being supplied, we have no heart function, essentially. That heart is going to start having lethal problems. So if you don't have that left ventricle being supplied, what type of things will you see with that type of patient?
Poor perfusion.
Yeah, poor perfusion being a big one. And those ventricular dysrhythmias, VTAC, VFib, which of course are lethal dysrhythmias. So if you have a blockage on this part of the heart, you're going to have a lot more problems than you are on this side. So when we go back to this slide, so here we have it shows which part, which if you look at the heart, you can see that the LAD supplies the septum, and then it's the anterior side of the heart, which is where our left ventricle is. The circumflex is the back side of the heart, which is like kind of the back side of the left ventricle and left atrium. And then the inferior side of the heart is supplied by our RCA. So when you hear of a patient that's had an anterior MI, if you hear anterior MI, you know that it's the LAD is where the blockage is. So, and then also if it's high enough up in that LAD, it can affect both the septum and the anterior parts of the heart. So that an MI affected by our LAD is going to be our most significant. And then of course, the left main is not on here, but if you look back at the pictures, obviously if it's the left main, it's knocking out all that, the circumflex and the LAD. So then when you look here, a left main is affecting all three parts of the heart, the septal, anterior, lateral. It's a big old MI that they would be truly lucky to survive. But then if you hear that they've had an inferior MI, you know that it's been the RCA that's affected. So there's a little saying in order to remember which parts of the heart are affected by which coronary vessel. So if you look down here, so you have Sally, S-A-L-I. Sally had 2 lads. She had sex with both of them, and that's not right. So I didn't make it up, but it's just a little saying to help remember, and you have to line it up so that way you know, oh, septal is an LAD, anterior LAD, lateral circumflex, inferior right coronary artery. So I don't have a saying for which leads correspond to which one, but if you look, they kind of go down the row. You know, when you have your septal, anterior, lateral, and inferior, you have your V1 and V2. Anterior, you have your V1 through V4, so you do have your V1 and V2 leads that do overlap with your anterior leads. Then your left lateral are the V5 and V6 with leads 1 and AVL. Inferior leads are leads 2, 3, and AVF. Now these leads that lead 1, 2, and 3, those are different than your V1, V2, and V3. So just make sure you remember that there's a difference there. So now when we go back to our EKG, now you're not going to need to know how to specifically read an EKG, but you do need to know, just if I tell you leads V3 and V4 have ST segment elevation. So which part of the heart has been affected? What type of MI is it? If I tell you leads V3 and V4, which would be right here, here's V3 and here's V4, and we're going to say that those leads showed ST segment elevation. So they're 2 contiguous leads. There's 2 leads of the same side of the heart, but what type of MI would you call it?
Is it anterior?
Yeah, an anterior MI. And then you should know, okay, if I tell you that it's a leads V3 and V4, I may not specifically ask what type of MI it is, but now you need to think about what type of symptoms am I going to be looking for in this patient. So if I know it's leads V3 and V4, now you need to think, okay, I know it's an anterior MI, and I know it's the LAD, and I know that the LAD supplies the left ventricle. So now you got to start thinking, okay, so they're going to have more cardiac output issues. They could have more ventricular dysrhythmias. So those are the type of things that you need to be going on with your thought process when you're thinking about what type of MI it is. Okay, makes sense? Clear as mud? Okay, so now our diagnostic test to confirm our MI versus our STEMI and our non-STEMI. Medication intervention is a big thing. If things are not being relieved by medication intervention, we're going to skip forward to our thrombolytic and, well, okay, not really our thrombolytics. Thrombolytics are an option, but very uncommon for an MI. Thrombolytics specifically are going to do blood clots. But as we mentioned, MIs are almost always or more commonly a result of plaque. So thrombolytics are not going to do anything for plaque. So that's why you almost never see I have never personally seen a thrombolytic given for an MI. But your text talks about it, and it is a potential option. But now with advances with cardiac caths and everything, you almost never see that done. One thing I didn't mention, we talked a lot about STEMIs, but our non-STEMIs, non-STEMIs will not have that ST segment elevation because it's not a result of a blockage in the coronary artery. It's still a result of decreased oxygenation to the heart that's causing a problem, causing that decreased oxygen supply and demand, or increased demand with a decreased supply, but it's not a cardiac event. Usually your non-STEMIs are a result of other disease processes. Shock is one sometimes. Anemia, severe anemia. If a patient comes in with a hemoglobin of 4, their heart is not getting enough oxygen when you have a hemoglobin of 4. So that can cause cardiac damage by not having that oxygen supply. So your non-STEMIs, so that's how you know that it's not an emergent, let's rush them to the cath lab, because if they don't have ST segment elevation, it's not heart related. It's an MI still, and there's still a problem. We need to fix it. And their heart is being damaged, but it's not because of the heart. It's because of another factor. So that's why you always hear STEMI activate and STEMI, because STEMI is an actual problem in the heart that we can try and correct as soon as possible. Whereas STEMIs, we got to kind of rule out and figure out what the other problem is if it's not in the heart itself. So our PCI, our percutaneous coronary intervention. Our PCI is our heart cath, and then our coronary artery bypass graft, our CABG, CAB, all the same thing. Bypass, just bypass in general, all the same thing. But these are all our potential treatment options for our STEMI patients. Medication intervention, we talked a lot about that stuff, but specifically for our MIs, though, when they're first coming in, MONA. If you haven't heard of the MONA before, it's their morphine, oxygen, nitro, and aspirin. We already talked about the aspirin and nitro. Our oxygen, though, is starting, we used to just put oxygen on everybody because, oh, it's an MI, it's an oxygen problem. The heart's not getting the oxygen that it needs. Yeah, that part of the heart isn't, but they could potentially still have an O2 sat of 98% on room air. If they've got a good O2 sat, you don't need to supplement them with additional oxygen, because we're finding now that oxygen toxicity is much worse. So if you give them oxygen when they're already a 98%, and now you're putting their O2 capacity way over 100%, we know our O2 stats will never measure more than 100%, but their actual oxygen carrying could be much higher than that, their arterial oxygenation. So when you have our oxygen toxicity, that causes a release of free radicals, which then can be very damaging too to the tissue. So now if their O2 stat is okay, we don't necessarily put oxygen on everybody that comes into the door with chest pain. And then morphine, I already mentioned morphine as far as, it helps decrease those circulating catecholamines and decreases the oxygen consumption. And it's going to depend. MONA is not in that order. It's just an acronym to remember the different treatment options. But generally, it's going to be our aspirin first, then our nitro. And then if our nitro is either contraindicated because their blood pressure tanks, then we might switch to the morphine that decreases blood pressure a little bit less than what our nitro would. All right, so we have our percutaneous coronary intervention. There's another link there if you're not familiar with a heart cath. the process of it, that's available for you to look at. Essentially, if you aren't familiar and you've never, been able to see one or anything before, they go in through the femoral artery, thread the wire up into the heart, find the block, put the dye in, find the blockage, and correct it. So with that, we have different options that they can do to correct that blockage. Our percutaneous transluminal coronary angioplasty, so that's our PTCA. PCI, PTCA, you hear those main terms used a lot. But what they do is they can go in with a balloon, open up the area of plaque, and get that artery to be reperfused again. Usually they're going to open it up with the balloon and then put a stent in place because they're higher risk to restenose or recollapse if they don't put the stent in place. But it is possible that they could just do the balloon, kind of slap open the plaque and push it up against the walls and be done. But usually that's not all they do. It's kind of usually the starting point. They could do the arthrectomy where they go in and essentially remove the plaque, kind of do like a roto-rooter type thing, break it up and remove it all and suck it out, and then potentially still place a stent. It really just depends on what they find when they go in there. If there's a lot of areas, they might just go in, put stents in multiple areas. But the biggest thing is that they get in and do that treatment within 90 minutes. The sooner that you get in and reperfuse that muscle, then the less long-term damage that they're going to have to that heart muscle. So 90 minutes is the AHA, your American Heart Association, is primarily 90 minutes, and your textbook says 90 minutes, but I'm pretty sure that the hospital's goal is 60 minutes. So if you're on the heart cath, the cath lab team or something like that, they generally have specific criteria that you have to live within 20 or 30 minutes to the hospital, so that way you can get there as soon as possible to get that patient into the cath lab and opened up within that 60-minute time frame. But the main standard is 90 minutes. And that is not just 90 minutes to get into the cath lab, but 90 minutes to literally open up that vessel. So door to balloon is what they generally say, within 90 minutes. And so post-procedure. So after a patient has had a heart cath, we need to monitor for potential complications. Of course, they're going to continue their therapy as indicated with medical management. They'll be on, that aspirin, Plavix, maybe a beta blocker, a calcium channel blocker, whatever their medical management is. Of course, they need to be compliant with that, diet therapy, behavior modification, smoking, all that stuff. But immediate post-op after a heart cath, we need to be monitoring for these things: arrhythmias, hematomas, restenosis, and bleeding. Hematomas is going to be your most common complication after a heart cath. These patients, they're going in through that femoral artery. So it's an artery, and it's a pretty large sheath that they put in place in order to open up that artery and then thread in and get to the heart. So they're at high risk for bleeding. So if you are monitoring that groin site, generally you have to monitor it every 15 minutes for like an hour, every 30 minutes for 2 hours, and every hour for 6 hours, and so on. So you need to monitor that site really, really closely because it is at risk for bleeding at the site specifically, but also a hematoma. So if they pop a hematoma, it'll be a hard, could be bluish, looks like a bruise, but like a hard area that you need to put pressure on and try and soften up and try and get the patient to stop bleeding in that area. So you just need to be monitoring for that really closely because it is the most common complication. And then bleeding, they could just overtly be bleeding from that arterial site after the sheath is removed, or they could have a retroperitoneal bleed. If they start to develop severe back pain, low back pain, they could become hypotensive if it's severe enough. But if they have that, then that's a big indicator that they have a retroperitoneal bleed. And you need to be notifying the doctor right away because you want to try and, they're going to just have to go back to surgery, and the physician likely is just going to need to suture up that area of the artery that has been, that is bleeding. you as the ICU nurse might be the one removing the sheath, or it might be removed in cath lab, and then they go back up to the telemetry floor, depending on what type of intervention they performed. But then the other things that you want to monitor for is restenosis and arrhythmias. The patient, especially like just a simple balloon angioplasty, if they just go in, open it up with the balloon, that plaque could fall back down, fall back together and close off. So they could, or the stent could possibly collapse if it doesn't adhere properly. The stent could recollapse as well. So you really want to be checking for signs of chest pain, because if they start developing signs of chest pain, that's a sign that they have restenosed, because they should not be having chest pain still after they've had intervention, because that heart muscle is now getting that oxygen and everything that they need. They should not still continue to have chest pain afterwards, especially if they start complaining of sudden chest pain. That's not a good sign, and that they've restenosed. And then arrhythmias sometimes can occur due to reperfusion. So especially if you have a patient who maybe has had this gradual plaque buildup, that the heart muscle just hasn't been getting as much oxygen as it needs, and until it completely blocked off. And now all of a sudden, bam, it's open, it's getting good perfusion, the heart's getting all this blood and oxygen that it needs to that area, and now it's just kind of like doesn't know what to do with it, and it can kind of like fluster it essentially, and it just starts having dysrhythmias. So you need to monitor for those things. That's not uncommon, but of course, if they go into a lethal dysrhythmia, depending on what part of the heart was opened back up, because obviously if it was like a ventricle or something, like the LAD that was opened back up and now the ventricle is getting all this perfusion, they could go into VTAC. More so VTAC than VFib, but it is possible for VFib that you would need to shock them and get them out of that as soon as possible. So those are some of the potential complications.
Sorry, I have questions.
Yeah, no, you're fine.
So like the reoxygenation, like, could that cause pain when they're having the arrhythmias?
Not typically with the arrhythmias, unless it's long enough that it's causing decreased cardiac output. But generally these patients come back to the ICU. I mean, they're going to come back to the ICU, and they are on that heart monitor, and you notice those things right away and get things corrected right away, because you should be watching for these continuously and prevent it from being too prolonged. But generally, the chest pain is going to come from stenosis and not reperfusion.
Okay. And then, like, is it typical, like, after one of these that they go home with nitro?
Yeah. They'll generally still go home with a PRN nitro, just in case for whatever. Yeah, well, we know how compliant some people are. So, some people don't want to stop smoking and don't want to change their eating habits and continue, with all those bad habits, and they wind up with plaque buildup again and restenose, either the same stent or they have other problem. I think the most stents I've ever seen, someone was like 19 stents or something. Like they just kept coming back in, and but so yes, they still typically will go home with nitro, just for PRN in case they start having chest pain again, for any emergent situation, or potentially sometimes if they wind up having enough blockages, but they feel that it isn't. Sometimes the areas can be small enough that they can't actually put a stent in if the vessel itself or the branch is small enough that they can't put a stent in. They might just go home and have them be treated medically, and then just go home with nitro and some of those other medications because they can't do a stent. So it varies from patient to patient, but typically they'll at least have some nitro on standby if they need it.
And then my other question was, I got to go to the cath lab at clinical on Monday. And it was really interesting and cool to watch, but they were trying to explain to me how they closed up the femoral artery, and they said they used a Minx procedure.
Yeah, I don't go into all those details, but yes, there's different ways that they can close. The most common way is just applying pressure and letting it essentially clot off on its own, where you hold pressure with either manual pressure with your hand or using the C-clamp to where it can hold down for that 30 minutes and just allowing the site to naturally close. But then some, depending on if they're going, like if they're just got a typical heart cath and they're just going back up to the telemetry floor. So that when you're going to do the manual pressure or holding pressure, that's generally if they come back up to the floor with a sheath in place and you as the nurse have to remove the sheath, because obviously we're not going to do any type of surgical procedure in order to close that site. So we just do the typical pressure. But they can do the Minx procedure. It's like where they do like essentially like suture it, and they suture it's a Minx like device in place to get the artery to have that closure. And then there is also, I'm drawing a blank on what it's called, but if they have, sometimes they do a band. If they do a radial approach, not very often do they do radial approaches as much, but they do sometimes do a radial approach, and it's like a pressure band that they put over the site, and then you just have to, like every 15 minutes, release like a mil of air until it's completely deflated, and then at that time the site should be completely closed. So there is different options, and it depends on where you're at, different facilities, different. Minx is a brand of it, so it really just varies from place to place. So, but yeah,
Okay.
you don't
But,
even
like,
know all that specific detail.
Your responsibilities after they get back up to the floor, it wouldn't change depending on how they closed it.
Right. Yeah. No matter how they close that site, you're still going to be monitoring for those things. Yeah.
Okay.
Yep.
Thank you.
You're welcome. All right. So then the other option, if their vessels are not a good option for stents, is our coronary artery bypass graft, our CABG, which is a surgical procedure in which the blood vessel is grafted to an occluded coronary artery so that blood can flow beyond the occlusion. It's bypassing the occluded artery, hence the name bypass. So sometimes it's used for those that have not responded to medical management. It can also be used if they've got severe two-vessel disease or moderate triple vessel disease. It can be an elective or emergent, and it can be done traditionally or minimally invasively. I primarily want you guys to focus on the traditionally invasive CAB, so our typical sternotomy, typical heart bypass, but the minimally invasive ones are starting to become more frequent, but the traditional is still the most common cardiac surgery. And the vessel, really depends on elective versus emergent, and the amount of vessel damage and all that plays a big indicator too. So elective would be more so if they went in and maybe they've been having stable angina, or they had a stress test that showed some blockages. They're going to go in, do a heart cath, and then, oh yeah, you do have some blockages. Nothing's 100% blocked yet, but we're going to go in. We need to schedule you for a bypass. So especially if it's multiple vessels, they're more likely going to do the bypass instead of placing like 5 or 6 stents at one time. So they're going to do the bypass. That would be considered an elective, but the emergent would be they come in with an MI or chest pain, and then they do that emergent heart cath, and they see, holy cow, there's a lot going on here, but it's too much to do stents for, but we can't wait. We got to rush this guy to the to OR right away and get this corrected. So that would be more your emergent situation. And then with your minimally invasive, then you have your mid-cab, that minimally invasive direct coronary artery bypass. This is where they do a thoracotomy incision and the 4th rib is removed, and they use the left internal mammary artery. So that LIMA is the abbreviation for your left internal mammary artery. They can use right also, but for this approach, they typically do the left internal. So they use that artery to be used for the bypass, for the artery that's going to bypass the occluded area. Cardiopulmonary bypass is not used, and the graft then is placed directly to the beating heart. So they don't have to be put on the bypass, cardiopulmonary bypass machine. So that is one option. Some physicians even they still do the traditional approach, but don't put them on the bypass machine. So they still do the traditional approach, but place the graft still while the heart is beating, which just like fascinates me. I could not imagine like doing those tiny little sutures on an actual beating heart and being successful at it. But there are a couple of surgeons in Fort Wayne, both Parkview and Lutheran, I believe, that can and do perform that. And then you have your transmyocardial revascularization. That is done more so for inoperable coronary artery disease, where they do laser channels from the muscle into the left ventricle to increase oxygen supply. And then there's a robotic heart surgery. So that's the endoscopic approach. But again, I want you guys to focus on our traditional coronary artery bypass. So I mentioned the grafts, the internal mammary artery. You couldn't use left or right. It tends to be the graft of choice because it's bigger and it just is more suitable for the coronary vessels. But the saphenous vein in the leg is also another option. The saphenous vein tends to be used more for emergent cases, which, you know, apparently it's easier to harvest emergently from the leg than the internal mammary is, which I don't really know why, because, I mean, they have the patient open, you know, their chest cracked open. You'd think it'd be easier just to get the internal mammary, but for whatever reason, the saphenous vein is used more frequently in emergent cases. But it's a vein and it's not quite as big. So if possible, they still prefer to use the mammary. If they do have the saphenous vein graft, if they do harvest that one, it's in the leg. So they do have like a skip incision. If you've ever taken care of anyone with after a bypass surgery and they've had that saphenous vein, they have that incision on the leg that you need to be monitoring that. Not only are you monitoring their sternal incision, but you're monitoring the one on their leg. And they tend to complain of more pain in the leg incision than they even do in the sternal incision. But with the leg, you have swelling and they're trying to walk and ambulate and stuff with cardiac rehab. So that could be some of the reasons why as well. And then they often have an incision even all the way up in the groin. So that incision tends to be the one that gets infected more frequently because it's in that groin, and especially for larger people, if it's just more moist and just a higher area for breeding bacteria. So you just need to watch those incision sites closely. Complications following our CAB. Hemorrhage is a big one. Of course, you're cracking open someone's chest and could potentially lead to hemorrhaging. Hypovolemia, dysrhythmias, bradycardia, tachydysrhythmias, bradycardias, all those things, everything. It just depends on what part of the heart is being affected. They could still wind up with an MI if for whatever reason they're not getting that heart muscle reperfused quickly. Cardiac tamponade being a big one. If they bleed into that pericardial sac, heart failure, stroke, acute renal failure, electrolyte imbalances, especially the ones that are affecting our heart are potassium, magnesium, and calcium. Liver failure, impaired gas exchange, atelectasis, infection, blood clots, pericarditis, everything. I mean, like pretty much everything can be a complication of a CAB because it's a heart. We need our heart to do all of those things, and it can, if anything happens, it can affect every body system. So with cardiac tamponade, some of the things that you're going to monitor in particular with your CAB patients is your chest tube. After a patient has had a CAB, they're going to have lots of tubes and wires. They're going to have that PA catheter monitoring their cardiac output. They're going to have an arterial line. They're going to have a central line. They're going to have chest tubes. They're going to have Foley. They're going to be intubated. Like literally every hole is going to be filled with some type of tube. But your chest tubes specifically, you will have a pericardial tubes, and then you will have your pleural tubes. Generally, they'll come back with like three different chest tubes, and they're going to be, I mean, generally it's pretty easy to tell which ones are the pericardial because they're usually going to be more substernal. So those chest tubes, you need to monitor closely for their output. If they start to have too much output, like over 100, 150 milliliters an hour, that's a bad sign. That indicates bleeding, of course. So you would want to notify the physician about that. But if they start to have too little output, or they suddenly have no output in that chest tube, that should be a red flag too, because they should be having some output. They just had major open heart surgery. They're going to be having some bleeding. They're going to have some fluid coming out of that chest tube. So if it stops suddenly, you have to think, okay, well, it's going somewhere, because I know they didn't just stop bleeding. So that should be your first clue that you should notify the physician, because something's either going, if you troubleshoot and can't determine any like kinks or anything like that in the tubing, the first thought is that, okay, the fluid is possibly collecting in that pericardial sac and could result in that cardiac tamponade. So both extremes you would want to notify the physician for, whether the chest tube immediately stops bleeding or if it's bleeding excessively. You're going to want to keep a close eye on those things. They could have that, could develop pericarditis with the inflammation and stuff, and understandably. So knowing that if they do develop pericarditis and they start having chest pain, that would be a normal process with the pericarditis and not necessarily MI related. But if they start having chest pain and they have no diagnosis of pericarditis, then that could be a problem and indicate your MI. So managing the patient post-op, measures to normalize cardiac output, which is basically everything below it. We're going to try and do our best to do everything we can to have that optimal cardiac output. So decreasing hypothermia. We know that patients coming back from surgery, the OR is cold. These patients have been in there for several hours. So we want to make sure they're warm, because hypothermia can cause hypertension, which then can cause bleeding. Too high of a blood pressure can cause bleeding, and those suture sites in the heart and everything can start bleeding and causing lots of problems. So making sure that we are minimizing those bleeding risks, warming the patient back up, maintaining adequate blood pressure, maintaining that chest tube patency. So we never, so you're monitoring the output of their chest tubes, and also you want to make sure that there's not clots and those type of things in there as well. If there are, though, one thing, there used to be like protocol that you stripped the chest tubes like every 8 hours. We no longer do that. Now you have to have a specific physician's order to strip a chest tube, which is essentially stripping a chest tube is like pulling on it and like how you would like strip a clot if it was like in there. But by doing that, you're exerting a ton of intrathoracic suction, essentially, when you're doing that. It's like pulling it, which obviously after someone who's just had their chest open is not a good thing. So that has since gone to the wayside. You only do stripping if a physician, if you know specifically there's clots there and you've got a physician order for it. Milking, you really shouldn't be doing on a regular basis. Typically they kind of say without a physician's order, but it really depends on some orders. You'll say will come through and it'll specifically tell you to milk the chest tube, which milking the chest tube is just kind of like what we do with our Foley catheters. If there's drainage in that like dependent loop, we kind of like manipulate it to get it to flow down into the bag. Same concept with your chest tubes, but again, doing that could encourage more bleeding. So you don't want to do that real routinely, and unless there's specific physician orders for you to do it like every 8 hours or something. Preserving kidney function still goes back with cardiac output, monitoring their urine output, their blood pressure, everything, making sure those kidneys are staying perfused. Promoting early extubation. So now these patients, as long as everything is going accordingly, they often are extubated by the end of the day after they've had their open heart surgery, and potentially even up and moving the very next day. So the sooner we get our patients extubated and the sooner we get them ambulating and up and going, the better outcomes they have. Decreases risk of infection, pneumonia, all those things. Well, and then preventing infection. So of course, incision care is a big thing, extubating so they don't have pneumonia, checking their IV sites and their lines and tubes and drains and everything, doing good hand hygiene before doing any wound care, all those things. And then home care instructions. So they just had a major sternotomy. They just had their chest open. So of course, they're going to have some restrictions. So educating them on their lifting restrictions, which generally is about 15 pounds for at least 6 to 8 weeks. And making sure that they're keeping up with their follow-up appointments and their medication management and, you know, all those type of things, and how to look for signs of infection and any other complications that could arise. I think that was it, wasn't it? Yep. Last one. So our pacemakers, or our implantable cardiac devices. So with our pacemakers, our pacemaker is an artificial device that electrically stimulates the myocardium to depolarize, which begins contraction. So it helps the electrical activity to stimulate contraction, whether it's in the atria or if it's in the ventricle. It's going to do what it's supposed to do to get the heart beating the way it needs to beat. It can be used with arrhythmias such as bradycardia, tachycardia, sick sinus syndrome, which is both. It's severe bradycardia 1 minute and then severe tachycardia the next. They'd have both problems. And then can be used for our atrioventricular blocks. So any of our heart blocks, primarily though your second and third degree. First degree usually doesn't necessitate a pacemaker, but our others do. And then our big thing is to resynchronize those ventricles in heart failure. So that's when we start talking about our biventricular pacemaker. So those really improve outcomes with those patients with heart failure. Excuse me. Our pacemaker has 3 parts. We have our pulse generator. So the generator is the powerhouse of the pacemaker. That's where it tells the pacemaker what to do, how everything is controlled in that area. There's batteries. Generally batteries last about 10 years or so for our permanent pacemakers, but then our temporary pacemakers are a lot different that we need to change with just your traditional batteries, either a 9-volt or even AA batteries. But either way, you have your generator that's going to control it all. Then you have your pacing leads, which your pacing leads are what, lead to the electrode tip. And then the electrode tip is where it's placed. Depends on what part of the heart it's going to originate that impulse to. So you have your temporary and your permanent. Your temporary pacemaker is going to be used more in emergent situations or like a bridge until they get their permanent pacemaker. So this is an old version, but still typically, kind of similar to what a temporary pacemaker would look like. You have 3 different types of temporary pacemakers. You have your transvenous, epicardial, and transcutaneous. Your transvenous is going to be, could be implanted at the bedside in an emergent situation with a patient who has, sudden severe heart block, complete heart block, or severe bradycardia or asystole, whatever the case may be, but it can be placed at bedside, and it's going to go, the lead wire is then placed through either the femoral, the brachial, or could be jugular. So the pacemaker is placed by the physician and threaded in to the heart to where it needs to go to generate that generate that impulse. Then you have your epicardial. Your epicardial is going to be your transthoracic approach. So after you have a patient with open heart surgery, they're going to come back with a temporary pacemaker, and it's going to be a epicardial. So those wires go directly in and are placed on the epicardial surface. So it's going to be, again, placed where it needs to be, and it's going to be threaded through that epicardial approach. And then you have your transcutaneous. Your transcutaneous are your pads. So your pads that are in place and would have to shock from the external surface. So with your transcutaneous pacemakers, those are definitely like super emergent. That would be like what you do as a nurse to get started until the physician gets there to place your transvenous pacemaker. So with that, as you can imagine, it's shocking them. It's definitely not as high of an amplitude as it would be for a cardioversion or a defibrillator, but it's still shocking them and getting their heart to get back into a normal rhythm and is pacing them. So it's going to be at a rate of 60, that's shocking them. So you're going to want to medicate those patients and make sure that they're comfortable and not too awake during that, because it's definitely not comfortable. But those are our different approaches for our temporary. And then our permanent pacemaker, it's permanent. It goes as the picture, usually on the left subclavian. It can be on the right subclavian, but generally it's on the left subclavian as long as their anatomy and everything is acceptable. That's the primary spot that you're going to see your permanent pacemakers. So with your pacemakers and your EKG, so what you will see with a pacemaker is a spike. That spike is the stimulus that the pacemaker is generating, and wherever it spikes, that's the chamber that's being paced. So you will see a spike before the chamber being paced. So a spike before the P wave, the atrium is being paced. A spike before the QRS, the ventricle is being paced, and you can have both. So when that happens, when you have a spike and then a P wave, that indicates our atrial depolarization. And then a spike before the QRS, that indicates our ventricular depolarization. So this is capture. This is what the pacemaker is supposed to be doing. It's capturing the rhythm and getting it to do what it's supposed to do. So here you have an atrial pacemaker. So it's just the atria being chased. There's just a spike right before the atria. Spike and then a P wave. Here you have the ventricle being paced. So you have a big spike because it's going to take a little bit more amplitude to get the ventricles to contract than it would an atria because it's a bigger chamber. So you have the spike and then the QRS. Now, this does not look like a pretty one. And they clearly have an underlying rhythm of like AFib or flutter, because there's really not the best looking, there's no real defined P wave there. But here you have a wide QRS and kind of like a notch in it. You have that like infarcted looking QRS. So typically with pacemakers, you are going to have a prolonged PR interval and a prolonged QRS. And that's because what's happening when you think about it, the pacemaker is generating the impulse and it has to travel through and cause the atria or the ventricle to do what it's supposed to do. So there's a slight delay essentially because it's not coming from the heart's intrinsic pacemaker capability. It's coming from a outside source. So it is going to be prolonged a little bit because of that little bit of delay. So that is going to be normal. Now this rhythm in particular, just clearly they got other issues going on too. Probably have had an MI in the past. They've got AFib clearly, but you will at least see a little bit wider of a QRS with a pacemaker. So here is your AV paced. So you have both the atria and the ventricles being paced. You've got two pacemaker spikes before each chamber. Here we have failure to pace. So failure to pace, so there's different settings in the pulse generator. There's output, sensitivity, and amplitude. So those, if they have a temporary pacemaker, those are some things that us as the nurses can adjust a little so that way it does capture and does give us the rhythm that we need. But in a permanent pacemaker, obviously it's internal. That's nothing that we can do about it. So you would just need to notify the physician if you start to notice any of these failure problems with the pacemaker. So this one would be, is called failure to pace. And as you can see, it's not pacing. So it makes sense, right? It's failing to pace. There's an output problem. It's not generating a spike when it's needed. And then you have your failure to capture. So the pacemaker is giving a spike, but it's not producing a QRS. So sometimes this could be an amplitude problem. Maybe the energy is not quite high enough. So it's getting the spike, but it's not enough to get that ventricle to fully contract. It is sometimes, but not every time. So you might need to adjust the amplitude there. And then you have failure to sense. So failure to sense could be the most potentially life-threatening because it's doing what it wants to do without sensing the patient's intrinsic rhythm. So sensitivity is something that that's kind of like a fence. The higher the sensitivity, the higher that fence is going. So if that sensitivity is too high, then the pacemaker can't see over that fence. It can't see what the patient's actual rhythm is doing. So it's still going to throw the spikes at the amplitude and the set rate that it's been set for, but it can't see what it's looking at. So it's still going to do what it's told, but not in regards to where it should do it. So what happened in this situation? It's throwing its energy, it's giving its pacemaker spikes, but not looking where it's at. And what did it do?
Threw him into AFib?
Not AFib.
VFib, sorry.
Yeah, VFib. But why? Why do you think it did that?
Because it was hitting the T wave?
There you go. Yep. So this can be very bad. So if you see something like this where there's just spikes that are not making sense with the patient's rhythm, then you need to notify the physician right away because they could potentially start throwing spikes on the T wave and cause the patient to go into VFib. We had a patient admitted to tele a couple semesters ago, and I mean, you know, I've worked in coronary for a long time with being in the float pool. So I was staring at the rhythm. You know, I had students up there. I wasn't taking care of any patients on my own. And I'm looking at it and I'm like, that doesn't look good at all. Like, that's bad. And I was like, have you guys called the doctor? Like, oh, no, they just got here. They came up from the ER. I'm like, well, I think you need to get him up here right away. And then that doctor came up, took one look at the rhythm and was like, yes, get that patient to CIC right now. Because this is what he was afraid of, that the patient was going to throw a spike on a T wave and throw him into VFib. So we wanted him to be monitored very closely in the ICU until they could get that fixed. So then we have our different settings of our pacemakers. We have synchronous, asynchronous, and overdrive. So our demand and our overdrive then would be like for our tachy and our Brady. So our demand would be our Brady, and our overdrive would be for our tachy. So bringing down the rhythm or bringing it up depending on what the problem is. And then our asynchronous or our fixed would be for like your asystole. Like their underlying rhythm is nothing. So it just needs to do what it needs to do, and without any regards to what the patient's rhythm is, because they have no rhythm. So generally your fixed is going to be for your asystole type problems. So the capabilities are determined by a coding system. You guys do not need to memorize this coding system. It goes by 3 letters. It's actually 5 letters, but typically what you hear is 3 letters. And your most common is going to be everything. Your DDD, your dual chamber that's being paced, your dual chamber that's being sensed, and it's going to do both as far as inhibit or overdrive. Yeah, inhibit and overdrive. So it's going to do both. So those letters determine, whatever letter it is, helps you determine what the pacemaker's function is. So the first letter determines if the heart is being paced or which chamber is being paced. The second letter determines which chamber is being sensed. And then the third letter shows what the capability is. So there is, so like if it's it could be like a ventricular, you know, if it's a V, then you know it's a ventricular. It could be a VVI. So ventricular, the ventricle is being paced, the ventricle is being sensed, and then it's inhibiting, which would be, you know, causing it to not go too tacky. But again, the most common one is going to be all, which I kind of feel like, why don't they just do, why do they even give the others as options? So if you're going to have a pacemaker, you may as well have one that does it all. That's my thoughts. But there is the possibility of the different ones. And then you have your biventricular pacemaker for your cardiac resynchronization therapy that I've already mentioned. You know, getting both of those ventricles to beat together simultaneously to improve their cardiac output and hopefully improve their ejection fraction and help decrease the amount of medications they need to be on, and just really improve their quality of life, because obviously the better cardiac output you have, the better all your systems are going to be, which that's what that BiV can do. And then your implantable cardioverter defibrillator, so your ICD. So you can have one pacemaker that literally does it all. You can have a BiV pacemaker that's a DDD, and it also has ICD capabilities. Like you can have it all, have the works, which frankly, a lot of most patients that have a BiV pacemaker, it's a BiV ICD. So you're gonna have that biventricular pacing, because with heart failure or cardiomyopathy or anything, you know, they're at a higher risk for developing those lethal dysrhythmias. So they're gonna wanna have that ICD that can cardio over or defibrillate them. So depending on what the patient's problem is, that pacemaker can sense the underlying rhythm and defibrillate if it needs to defibrillate for something like VTAC or VFib, or it can cardio over if it's something like VTAC with a pulse with, or AFib with RVR. It can cardio over and get them out of that dysrhythmia. Complications of pacemaker use. So here you have local infection. We know infection with any type of surgery, any type of procedure is always going to be a potential complication. So they can have infection at the insertion site, but that's going to take some time. You're not going to notice that in the immediate post-op. The rest of these complications are going to be the things that you're going to constantly be on the lookout for in the immediate post-op period. So pneumothorax being one. Generally, you know, if they're going to have an incision and they're going to be placing a pacemaker in that subclavian area, it is possible that they could puncture the lung. So you're going to be monitoring for shortness of breath, restlessness, hypoxia, diminished breath sounds, arrhythmias, those type of things. Bleeding and a hematoma at the site. Again, bleeding is a potential risk for any type of incision, and a hematoma. It is possible that they could develop a hematoma, and I learned that it can even go down into like the armpit. I had a patient once that had was complaining of, you know, just like shoulder pain and just like armpit. It's like, oh, it just hurts. And I'm like, well, you know, you just had surgery. It's gonna hurt. They, you know, have to move your arm and manipulate things in order to place a pacemaker. So it's gonna be sore. But they typically have a sling on after they come back, or they should have one placed fairly quickly or fairly soon after that to prevent them moving that arm too much, because they can dislodge their leads that are not, that don't have scar tissue built around them yet. So lead displacement is a possibility. So they shouldn't be moving their arm a lot. So, you know, it's like, oh, you know, you're fine, fine. But then he kept complaining of it more and more and more. And then finally I'm like taking, you know, I'm like, what is going on? Everything looks fine. Like this all looks fine here. Oh no, he had like a golf ball size, or not golf ball, softball size hematoma like in his armpit. It was huge. And you know how hard it is to hold pressure in an armpit? Like, it's really awkward. So be checking everywhere for those hematomas. And then they can have ventricular ectopy, tachycardia, again, because they just manipulated the heart and are manipulating the electrical activity of the heart. They can go into some of those dysrhythmias. As I mentioned, the movement or dislocation of those lead placements, that is very common. So you have to do a lot of education and explaining to them why they don't want to be moving that arm, you know, especially above the shoulder raising, because that can really dislodge the leads. They need to try and do minimal movement with that left arm for several days to a couple of weeks. Then phrenic nerve, your diaphragmatic or skeletal muscle stimulation, if the leads become dislodged, or if that energy is set too high, they can start having hiccuping. So if they start having like those rhythmic hiccuping, and it's not your typical hiccups, it's literally, I mean, it's like the rate of what their pacemaker is set at, and it's not life-threatening, but as you can imagine, it's very annoying for the patient. So if they start hiccuping, you'd want to know notify the physician, because either the lead has been displaced or they have set that MA too high and they needs to be decreased. And then cardiac perforation, pericardial effusion, and potentially cardiac tamponade. Those are all possible, but much more rare. And then there are all those things that I've already mentioned, your failure to capture, sense, or pace. If you notice any of those things on the EKG rhythm, you'd want to notify the physician as well. Discharge instructions, you're going to instruct your patient to take their heart rate daily. And if it is at least 5 beats less than or 5 beats above their set rate consistently, they need to notify the doctor. So if their pacemaker is set for a rate of 60 to 100 and they're consistently, like, even a couple days in a row, or they check it in the morning and at night and then the next day or whatever, if it's consistently below 5 beats or above 5 beats above their set rate, they should be notifying them, because something's not quite right as far as their settings go. And then encouraging them to take it easy for a couple of weeks. As I already mentioned, no above the shoulder activity, driving restrictions until they're stable. Again, they're obviously not going to want to be driving if they have restrictions on the arm. Avoid swimming alone, especially if they have a defibrillator and they are one that is at risk for being shocked. Maybe they got an ICD specifically because they have those ventricular dysrhythmias. We don't want them getting shocked and passing out in a body of water all by themselves. No lifting over 25 pounds until that's completely healed. Avoiding rough contacts, and then avoiding electrical and magnetic fields. So cell phone, cell phones are kind of like old, like kind of old school now, that now it's really not going to affect it, but they do still say things like, don't fall asleep, like with it laying on your chest or something like that, because it could potentially affect it. But the main thing is your magnetic or high voltage things. So if they have any type of occupation that involves those things, they may not be able to continue with that. And MRIs, there are some pacemakers now that have MRI capabilities, but you would have to know specifically that pacemaker is cleared to have, for the patient to have an MRI. Otherwise, generally speaking, patients that have pacemakers do not get MRIs. So if the patient is touching, or if anyone is touching the patient when the shock is delivered, they will feel an electrical impulse. I have been holding the hand of patients who have been defibrillated before, and I've never felt it personally. I have heard some people say that they have felt it, but I'm sure it depends on a couple of factors. One, how high their amplitude is and how much energy they're getting with that pacemaker or that defibrillator, and where you're touching them. Like if you have your hand, or if you're holding them on their chest or something, I imagine you're going to feel that more than if you're just holding a peripheral body part like a hand or bound by the feet or something. So I personally have never, but it is still possible. It's not going to shock you into a rhythm. It's not going to be strong enough to really do anything to you, but you could feel that impulse. Household appliances, so like microwaves, stuff like that, are not going to affect the function, so that is fine. They will set off the secure airport security detectors. It's not going to affect their function, but that's why it's important for them to carry the ID cards with them at all times. So if they do go through that airport security and it goes off, they have their ID card. And they should too, because then they should not have the handheld scanners, because that can affect the function of the pacemaker. So that's why it's important to carry that ID with them. So you can be like, nope, I've got a pacemaker, that's why it went off, and no, do not do that over my pacemaker. And then reporting signs of dizziness, fainting, fatigue, weakness, chest pain, hiccuping, or palpitations. Other than the hiccuping, all the rest can be damage, causes of decreased cardiac output, but the hiccuping, again, could be the leads have become displaced. And then no tight clothing until this incision is completely healed, because you don't want to irritate that and cause any risk of infection. Okay.